thank you very much for coming. It's a pleasure to be here with you. I see a lot of familiar faces and hello. So I was given the task of talking to you today to you about genetics and a concept we called minimal residual disease negativity that you're going to see a lot about. Before I start, I should tell you, my father had an administrative career. He was an accountant, and my son is going into law school. So I won't have any legacy like myself for myeloma. So maybe I could adopt one of the Bergsago kids and then try to go into that realm. So, but yeah, thank you for being here. I think Leaf does a great job just providing the historic background. I'm going to show you some curves. I want to explain them a little bit further, how we read them and what they mean. But I'm going to give you an example of a study we published a year ago that uses this concept of big data. And I think Health Tree is going to be one of those opportunities for putting out big data. Now, this is a study we did using a claims data set from insurance companies to try to estimate what are we doing with survival for myeloma. So it's always hard, and we don't like to see this curve. So let me just explain what they mean. If we all lived forever and no one in society, passed away, the curve would be flat like this. So every time there's an event and one of us leaves, the curve goes down a little bit. And what I'm showing you there in the bottom part is data from an insurance database for myeloma patients. And what you can see is we can break it down by the year of diagnosis. And I show you this for two reasons. First of all, you can see how this starts fanning upwards. We see a significant improvement of that. And in fact, using this claims data sets, if you go at the 5 years, you're right there around the 70% that Dr. Bergsago was pointing out. But I want to highlight this stops at 2012 because that's where you need some follow-up to be able to do these curves. So in 2012, we really had not seen the impact of two drugs, carfilzomib and the Darzalex, daratumumab. So I think as we imagine this curve again a few years from now, as Dr. Bergsago was showing, I think it's just logical to conclude that it will continue to fan upwards. So that is our hope, and we're hoping again through efforts such as with Health Tree, which has a great advantage over this. So this data set was very powerful because it had large numbers. There's 9,000 patients, but it has a limitation. This is just an insurance claim. So we just know there's a diagnosis, and based on that, we make the study. As you start incorporating the genetics, the fitness, the treatment, the duration of treatments, I think that makes a huge difference in how we're going to understand this. And I'll show you an example of how we're using this data in other sets. So why genetics? And before I do that, let me just say a few words. When it comes down to genetics and myeloma, what we're talking about is the genetic changes that happens in the cells that give rise to the myeloma. And I cannot emphasize this enough. We're not talking about genetics as we think of them that we pass on from generation to generation. This is not the hereditary part of genetics. These are hiccups that happen in those myeloma cells that make them become the myeloma cells. In no small part, we know about this because of the work of people by Dr. Bergsago, that we understand that little hiccups is what gave rise to multiple myeloma. Now, like if you're writing a story and you put a typo, almost always nothing happens and you laugh and you see the typo. But every now and then, missing a comma or the wrong typo can change the whole meaning of a story. And that's what happens with the genetic changes in myeloma. Those typos, we know which ones they are. We know which ones are the ones that happen on a regular basis. And now what we're doing and have been doing for some time, we can use that information to think, okay, this is a myeloma that is more likely perhaps to be a bit more aggressive, or this is a myeloma that's going to be more stubborn but less aggressive, or this is a myeloma situation where we have to think about a different drug. That is the value of genetics, number one. Number two, these genetics are not present in any other cell of your body. They're just exclusively present in the myeloma cells. So the muscle cells, the bone cells, our heart, our brain, everything is normal. It's just that little hiccups that happen, unfortunately, in the cell that gives rise to the myeloma cells. So I'll give you an example of how we're using this. This is a study we published almost 15 years ago now, where we actually looked at how we could create these different subtypes of myeloma. This is always something that is evolving. And we said, okay, if you have these markers, what is the likelihood that you're going to have events sooner? Now, if you look at this curve, and you go back at the one we have here, you see quite a difference in how the slope of those curves has changed. Back then, it was mostly the melphalan and the dexamethasone we had for these patients, but none of the new drugs. But at the time, we realized what you see in the blue curve means that that's kind of the most risky and dangerous situation. Back then was patients who have this abnormalities, what we call the translocations, the 414, 1416, and the loss of a little segment of chromosome 17. And if you read the medical literature, this still remains as one of the key ways in which we myeloma doctors think about more aggressive forms of myeloma. There's even better ways to determine this right now, but this is how most of the medical literature, still is reported. I don't think it is crucial to explain the technicalities of how translocations occur. Just know that a translocation is, I call them a little bit like swinger chromosomes. So you have a chromosome 14 here, you have a chromosome 11, and 14 normally is going through a lot of, cut and paste, cut and paste, cut and paste. And if it just happens to be very close to, for instance, 11, if someone has an 11-14 and 11 has a break, they switch partners. So now it's a 14 with a little segment of 11 and an 11 with a little switch, a little fragment of 14. It's kind of like pens exchanging their caps, if you may. That's what a translocation is, and that is one of the key seminal events that gives rise to myeloma. Now, and that we use that, and we've used that over the years. Now, this is very, very important, and I know, I see some faces in the audience that I know you know this. This is not deterministic at 100%. It just tells us there's a high risk that things may not go the way we want. In fact, we have patients who have these markers who can do very, very well in the long term. It just changes how we think about things. It's not like you got this and it is predetermined that you're going to have this outcome. Likewise, we sometimes unfortunately see situations where someone doesn't have any of these high-risk markers, and yet, the clinical course is that, it's more aggressive. So none of this is deterministic. It just gives us a framework on how we start thinking about this myeloma cells. Now, how we test this, we currently test this routinely in the clinic by the Testicle Fish, which stands for fluorescent in situ hybridization. What you see there is, I think it's a beautiful image. I've always loved to see fish images. What you see in the top part, the blue, that's a myeloma cell. It's been painted with a dye that makes it look blue, so we can only score the myeloma cells. And then you see those little dots, the red and the green, and we kind of ask the questions, okay, how many dots do we have there? Are the dots separate? Are there dots together? And with these questions, we can make some determinations. Is there a chromosome that is lost? Is there an extra copy of chromosomes? Are two chromosomes together when they should be apart? And that's how we read actually the fish results. In the bottom part, you see a normal neutrophil. So if you have had a transplant, we're waiting for those to come back. That's a neutrophil in person. So you know how they look like. And as you know, they all have the same genes and chromosomes, and that's why the probes go there as well too. So I won't spend a lot of time talking to you about this, which Leif already showed, this idea of the heterogeneity. But I want to make a couple of points because Greg asked me, make some comments about how genetics matters when it comes down to treatment. And Leif already alluded to this with this particular graph. Each one of those colors represents what we call subclones. Okay, so that's what you can think of them as like mini tribes within the myeloma. So if we take 100 cells from a myeloma bone marrow, there's some that have this feature, some others have this other features. However, there are two things that are critically important about this. Number one is these cells are a lot more alike than they're different. This is like those games they show you two pictures and they say find the difference. That's what this represents. So they're tiny differences, but they can make a world of a difference in how someone responds to a treatment or not. So that's number one. Number two, I'm gonna change this graph into something different. What do we see is that some of them come and go depending on what treatment it's applied to a person. But there are some things that always stay with that myeloma cell. And now that's what I show by that little black dot in the center. That's kind of the soul of the myeloma cell, a soul we don't like. That may be a translocation. So if someone has a myeloma that is 11-14, every single one of those cells is going to be 1114. There's going to be tiny different changes that make those cells different. Now, why do I tell you all of this? The point of this, which Leif alluded to, is because if you press in one area, then maybe there's the opportunity to escape in another area. Our current thinking is that we need to be more encompassing of trying to block all the exits for the cells. And that's, in our mind, means usually go with 3 drugs instead of 2 drugs, and usually treat for longer and try to treat for deeper. That's a very, very important concept. So that's one of the reasons why we like to think about these concepts. Now, how does this matter? You're a patient, you're saying, well, how does this matter? Like, this is a great example of opportunities and diversity and how the cells can adapt. Because if you have cells that have all sorts of little changes, there could be a few cells here that maybe are not going to respond to Revlimid. And if that person is placed on Revlimid, all these other cells will go away, but those that are Revlimid refractory are going to start growing and taking over. So what this variability or diversity or heterogeneity gives is the myeloma cells an opportunity to still persist despite treatment. That is what we're trying to overcome. And actually, Greg asked me to show this slide, which I sometimes show when I talk to doctors, which is the story about the lion and the gazelles. And as you know, this is an African story that every morning they both wake up and the gazelles say, we have to start running and be ready to run because the lion is around. And they know they just cannot be as slow as a gazelle. And the lion wakes up and goes, I need to start running. I don't need to be that fast. I just need to catch a slow gazelle and I'll eat. And they eat, of course. But what happens is over time, over millions of years, the gazelles are still there because the lion needs to run as fast as a gazelle. And that's what we're trying to do with the design of myeloma clinical trials. We're trying to get ahead of the very fastest gazelle. And that's what we're trying to do with a combination of drugs and treatments that would ultimately, catch all of those myeloma cells. So when we talk about treatments, by the way, that story about dexamethasone is beautiful. The drug that makes everyone else stupid. I was laughing out loud from that. So that's why we go with all these combinations to try to be all encompassing for myeloma. Now, this gives us a lot of information. We're integrating this into the clinic. I'm going to show you a few things that are very important. Myeloma comes in about 7 or 8 flavors, but at the very top level, there's 2 flavors, 2 types. One is the ones that have the translocation, and 2 are the ones that have extra copies of chromosomes that we call trisomies. And there is a mouthful there that is the hyperdiploid version of multiple myeloma. Now, I'm going to show you here on the right side, my arrow shows, the commonality of this translocation goes down, so the frequency goes down, as we advance in age, and the frequency of this variant, the hyperdiploid, goes up as we advance in age. So it's more likely that we will see hyperdiploid patients that are older and younger patients that have the translocations and high-risk multiple myeloma. It's not absolute, as you can see, but there's a trend for that. And this is important because sometimes for myeloma patients who are younger, we'll go sometimes more with this approach of what I'm calling now, we're trying to establish the Pax Romana. We want to put full control and keep that control. For some of our patients who are maybe in their late 70s and 80s, it may be enough to be more in the control mode. And that's often what we do with our treatments. I wish we had a crystal ball for every patient, but these are things that we're thinking as we think about treatment. Of course, it's a much easier thing to propose a transplant than someone who's in their late 50s, early 60s versus when they're in their late 70s. But also we have the opportunity that sometimes you don't have to do the full extent of the treatment. Now there's other ways in which we can talk about risk, and one of them is this gene expression profiling, and you probably will hear a bit more from Dr. Morgan, which can, it's another way to look at prognosis and try to separate those patients that actually may have a more aggressive form of myeloma. So that's one of the ways. There's actually a commercial assay that's available too for doing this through this Sky company that can test for the high risk markers. Now, one of the things to think about with these 2 things is that Again, number one, prognosis is not determinant. It's not a black and white. You have this, you're going to do well. You have this, you're going to do bad. We still are going to work together through those things. And you know, the other thing is that these are only approximations because there's many other things that come into play. You know, if you come to the clinic and a person has, you know, severe diabetes and heart failure, it's going to be a lot harder to get going through the completion of the treatment. So all of that plays out on how we're able to propose different treatments for patients. In the interest of time, I'm just going to say a few words about this test also that we're doing, minimal residual disease testing. There's different ways of doing it. The way we do it here is through an assay that is done through genetics. And this is a test that we're doing to try to determine the extent of the response that we're able to achieve with treatment. And I call it as like B-cell fingerprinting. We can run a test on bone marrow samples that can tell us if there's any residual myeloma cells up to a certain level of sensitivity. The way we run this test is as follows. Let's say there's a myeloma patient here, and this patient is, you know, at the time of diagnosis, we collect the sample, and we determine what that fingerprint is. This is all through genetic method, through sequencing. We call that PCR. And once you have that, then you can run that test on samples in the future and see if there's still residual cells that remain in that bone marrow. Our current level of sensitivity goes to 1 in a million cells. What that means is if we give 1 million cells to the lab, they can give us an answer whether there's cells there or not. Now, that test cannot tell you for sure that there's no myeloma cells elsewhere in the body. But what it can tell you is within those 1 million cells that we tested in the bone marrow, there's no detectable myeloma cells. So there's a little bit of a difference there of how we interpret this. This test does not mean that there's evidence of no disease. It just tells us that there's no evidence of disease at 1 in a million cell sensitivity. That's a difference, but it's a very, very deep way of testing for myeloma cells. So we're using that, you know, we use that as patients kind of, you know, go through the phases of treatment. And if one of our patients, as we hope for everyone, that they get into a complete response, they get there, then we try to measure if we have this minimal residual disease status as negative or positive. And you know, in general, we like this to be read out as negative. That means we want that test to show us that there's no residual cells. But we still have a lot of questions, and we're still learning how to use it. So for instance, let me just walk you through this. You have a patient with smoldering and MGUS that progresses to myeloma. And then the patient goes through treatment, and these are the results we see after treatment. So if we have still residual myeloma, say after a stem cell transplant, well, that worries us, and we think about, you know, the need for additional treatment. Now, sometimes we can have some patients that may have, for instance, some cells that are back there in the background, like MGUS-like cells, and we think we don't necessarily have to treat all patients. We don't fully have the tools to know exactly how to do all of this, but this MRD testing is helping us get closer to understanding which are the patients that are going to need additional treatment versus which are the patients that we may need to back off. So you'll hear us talk more and more about this test, and I'm sure as we interact in the clinic, in how we're using this for making some treatment recommendations. There is a clinical trial that recently incorporated this, and it's a trial that looked at the comparison of transplant versus no transplant. In the myeloma community, it's now saying amongst us that we spent the first 25 years showing that transplant was good, and now the next 25 years are going to be to show that we don't need transplant anymore. But what this trial showed is the VRD arm was a no transplant arm, and this is the transplant arm. This trial has shown that all the markers, all the arrows point that transplant helps patients and is better. And I myself am inclined to think that transplant is a very important component of treatment. However, if without transplant you were able to get to MRD negative status, your results were as good as if you did that with transplant as well too. So we're kind of scratching our heads with that. This is a retrospective analysis of that data set, so we don't really know exactly how to interpret this, but one of my patients, and he's not here in the audience, came to me with this particular graph. He was a patient of Keith Stewart who said, I need a second opinion because I don't want to do a transplant. So he showed me this graph and he said, well, if the French study shows that I'm MRD negative, I understand that the transplant does not help me a lot more. I said, well, yeah, it's very preliminary data, but long story short, we talked for a long time and we did a bone marrow and we tested for MRD. And guess what the results were? One cell. The report read out as one cell. And of course, after a long discussion, he decided not to do the transplant. Anyway, even though it was not technically positive, it was at a very low level. And the patient has continued on treatment, and now the patient is on maintenance and is doing very, very well with the treatment. The point being is, we, alongside with you, are still trying to understand how do we integrate this test into how we make clinical decisions. There are some patients who have had a very, very long-lasting complete response. Patients who can have a complete response even when they had high-risk markers. And if the MRD is negative, we at least have entertained the conversation. Should we, for instance, think about stopping maintenance treatment in these scenarios? So we don't have the answers. When you hear us talk, we might even say sometimes things that are sometimes contradictory amongst ourselves. But in a way, that's good, because that's the status of the science when it comes down to myeloma. It's a very rapidly evolving field. We don't have the answers, and that's good. Fields that have the answers, either they have great answers and they've stopped, or they simply don't have good options. But that's where we are in multiple myeloma. So I think with that, in the interest of time, I'm gonna finish you. I'm gonna show you a quick image just to finish that I now show to residents and fellows when I talk, which is a good way to remember the protein electrophoresis. So there it is. And if you think about it, if a patient has an M spike, the only thing you do is you put the thumb upwards a little bit. So thank you very much. I appreciate your attention.